I'm going to be speaking to you about obstructive sleep apnea, diagnosis and treatment. First, these are disclosures of groups that I have been a consultant for. This is the usual clinical picture that we get. A partner brings in their spouse complaining about a lot of loud noise and how disruptive they are to their sleep. It then becomes important to us to diagnose and treat this. The take-home message for today's talk is really here, and I'll try to fill this in as we go further. Obstructive sleep apnea is common. It's dangerous in terms of having significant health consequences, easily recognized, and quite treatable. Before we start, we need a few definitions. What is an apnea? It is by definition a total cessation of airflow lasting for 10 seconds or more. In addition, we also have to talk about hypopnea, which is a reduction in airflow, so that which results in either an arousal from sleep or a drop in oxyhemoglobin saturation level after lasting for at least 10 seconds. The physiologic consequences of the two of these are pretty much the same, so we're going to lump them together when we talk about sleep apnea. There are three patterns of apneas that we want to know about. The one we're going to talk about today is obstructive apnea, and that's what you see here, a total lack of airflow, but continued effort and, in fact, increasing effort to breathe over the course of the event. In contrast, there is the central apnea. Again, total cessation of airflow, but in this case, the airway is open and no effort is made to breathe. The last pattern is called mixed apnea. In this case, again, total cessation of airflow, and the event starts with no effort to breathe. But as it progresses, the patient begins to make efforts, and since the airway is closed, they're unable to get any air in. The effects of the mixed and obstructive apneas are essentially the same, so I'm going to, again, combine those as we talk about sleep apnea. So, obstructive sleep apnea is a disorder of sleep and breathing due to repetitive collapse of the upper airway that results in awake symptoms, particularly daytime sleepiness, impaired performance, as well as a number of cardiovascular complications. I mentioned that it was a common disorder. How common? This is data from the Wisconsin sleep cohort, in which they brought over 600 people into a sleep laboratory and looked at their sleep. And what they found was that 24% of the men and 9% of the women had more than 5 obstructive events per hour of sleep. When combined with the symptoms of daytime sleepiness, which gave them this sleep apnea syndrome, they got what is the current prevalence rate for obstructive sleep apnea, 4% in men and 2% in women. For comparison, the rate in this country of asthma is about the same, showing how common this disorder really is. The pathophysiology has to do with the shape and size of the airway and the change that happen with sleep. This is the upper airway, nasal passageway, nasopharyngeal area, oropharyngeal area, and hypopharynx. The collapse can occur anywhere within this site, as you can see here on this slide on the right. You can have the palate falling back and blocking the airway, the base of the tongue, or the side walls coming together and blocking the airway. While awake, people don't have obstructive airways. This is a disorder that's related to the sleep state. When you take a look at people who have sleep apnea, they typically have smaller airways than those who don't. And while awake, they're able to keep the airway open through increased stimulation of the upper airway muscles, what we call neuromuscular compensation. However, when you fall asleep, you lose this neuromuscular compensation because of which causes decrease in pharyngeal muscle activity, allowing the airway to collapse and resulting in apnea. This is essentially a period of asphyxia. You can't get air in or out. And as a result, CO2 levels rise, oxygen levels drop. Both of these are potent stimuli to breathe, and you see increasing ventilatory effort in attempts to breathe over the course of the event. Eventually, this increased work of breathing triggers an arousal for sleep. Once you've gotten to the wake state again, you can restore that neuromuscular compensation, increase muscle activity, and the airway opens. In order to correct the blood gas derangements, you see a period of hyperventilation. And once you have corrected the hypoxia and hypercapnia, the person can fall asleep again. But this starts the whole process over. And it is this repetitive cycling that results in the symptoms and consequences of sleep apnea. The clinical consequences, again, directly related to those events. The repetitive awakening from sleep to open the airway fragments sleep, makes it non-restful, and results in daytime sleepiness. The combination of sympathetic increases with arousal plus hypoxia and hypercapnia give the cardiovascular compensation, and the combination of the two of these lead to the morbidity and mortality associated with sleep apnea. What are those consequences? Well, from the fragmentation, you get sleepiness, which gives you increases in motor vehicle and work-related accidents, decreases in cognitive and job performance, and overall decreased quality of life. On the cardiovascular side, systemic hypertension is very common. 60 to 90% of the people with obstructive sleep apnea develop hypertension. Cardiac arrhythmias, bradyarrhythmias, atrial fibrillation, ventricular arrhythmias, all more common. Increases in myocardial ischemia and cardiac events, increases in stroke, and as an end stage, you can see pulmonary hypertension and cor pulmonale. The combination of this leads to what's known as the Pickwickian syndrome. This is a look at mortality, again, from the Wisconsin Sleep Cohort, in which they took almost 1,400 people and followed them for up to 20 years to see what would happen with untreated sleep apnea. And you can see that the more severe the apnea, the lower the survival compared to people with milder disease or even those with no disease. And this is adjusted for most of the other cardiovascular comorbidities. Why does this happen? Well, this is information from a patient sleeping with an arterial line in place and having apnea. You can see here, no airflow, increasing effort to breathe, associated with drops in oxyhemoglobin saturation level. If you notice here, this is what the arterial line shows you. These increases in both systolic and diastolic blood pressures associated with the arousal from sleep, the dropping back down. This is usually about a 30% change in pressure. And when this happens over and over during the night, it eventually leads to the development of systemic hypertension. This is data from a prospective study looking at the association between hypertension and apnea, dependent upon severity or frequency of events. And you see here the apnea-hypopnea index, which is the number of events per hour of sleep. As that goes up, so does the likelihood of developing hypertension, where those with more than 15 events per hour have almost a threefold increased odds ratio, even when adjusted for most other factors. So who is likely to develop sleep apnea? The number of risk factors. Probably the most common we see is obesity. As weight goes up, so does the likelihood and severity of apnea. Increasing age, the older you get, the more likely you are to have apnea. Male genders with, depending upon the study, a 2-to-1 to 10-to-1 increase in risk for men compared to women premenopausally. Any anatomic abnormality of the upper airway that leads to reduction in size. Positive family history, likely due to genetic coding for the shape of the jaw. And anything that's going to decrease muscle function, like alcohol or sedative use. Interestingly, smoking is an independent risk factor for unclear reasons, likely, however, due to kind of edema or swelling in upper airway tissues. And then any other associated medical condition that can affect muscle function or airway size. So as a primary care physician, well, how would you evaluate for sleep apnea? And you can do it in one of a number of settings. There should be questions about sleep apnea in any routine health maintenance exam. Looking forward in people who come in specifically of symptoms related to it, like snoring, stopping breathing episodes, or sleepiness, or screenings in high-risk groups, such as overweight people. If you then get disorders, symptoms suggestive of a sleep disorder, they should undergo a complete sleep evaluation, which should include testing for sleep apnea. So what can you do in your routine health maintenance? There are some simple questions you can do with screening that don't take very long and will tell you about their risk. First, is the patient obese or retinopathic? Do they complain of daytime sleepiness or snoring? Or do they have hypertension? A positive response to any of these questions should trigger a more comprehensive sleep evaluation. What should that include? Well, start with the history. Is there a history of loud chronic snoring, a history of nocturnal gasping or choking during sleep? Now, both of these things are things that the patient isn't going to be aware of. So it's really important to ask the bed partner if these are going on. Automobile or work-related accidents, especially if related to being sleepy, cognitive problems, any of the risk factors we previously talked about, and the presence of excessive daytime sleepiness. So how do you evaluate for sleepiness? It's one of those things that often is not recognized by the patient. And so you really need to ask other people about this symptom. It is very common for me to have a couple in and I say, "Are you sleepy, Mr. Smith?" And he'll tell me no. And Mrs. Smith will chime in, "What are you talking about? We don't go anywhere anymore because you fall asleep all the time." When this has been going on for a long time, the patients don't recognize the problem. You also need to ask specific questions to differentiate between fatigue and sleepiness. So will you tend to fall asleep in things you don't want to, or do you have trouble staying awake when you want to? Have you had any problems with automobile accidents or near misses due to being sleepy or falling asleep in inappropriate settings, such as in work or social situations? The findings on physical exam are nonspecific but suggestive. So the presence of obesity, particularly upper body obesity and a thick neck. A neck of 17 inches or greater in males and 16 inches in females is correlated with an increased risk of sleep apnea. Because of their association, you should look for it in anyone with hypertension or an obvious airway abnormality, such as these two who have different degrees of retromicronadia, both of whom had severe obstructive sleep apnea. So I'm going to ask a case history now, and then we'll give you a chance to weigh in. So the patient presented with, after having passed out while driving, didn't remember what happened, but had been sleepy and fighting staying awake on the drive prior to the accident. He falls asleep frequently at work and at movies, and his wife no longer sleeps with him in the same room due to very loud snoring. On exam, he was obese, hypertensive, had a big neck, and on exam, his oropharynx was very crowded. The question for all of you is then what should be done next? So please make your selection. Okay. So I think most of you figured out that the answer to this was the person was at high risk for obstructive sleep apnea and should get an overnight sleep study to look. Why, given the clinical history being pretty obvious? Well, you need to document the presence and severity of sleep apnea. The symptoms themselves poorly predict disease severity, and appropriate therapy depends on knowing the severity of the illness. There are other things that can cause daytime sleepiness, and you can rule them out with the sleep study as well. There are several types of overnight sleep studies, ranging from in-laboratory full-night polysomnography, in which the person comes into a sleep lab. This includes being able to get what's called a split-night study, where half of the night is diagnostic and the other half is a PAP titration. There are also home diagnostic systems, which range from single-channel oximetry to full polysomnography. Most common, we do multi-channel, about 4 to 6 channels in a home study. This is the information that you get from an in-lab study. You can see here these top channels are EEG, telling you when they're awake and asleep when combined with eye leads and muscle tone. This is heart rate. You can see the variation that occurs. And down here are the respiratory channels. So this is airflow, and these are effort belts. This is pulse oximetry. And so what you're seeing here is a period of no airflow, increasing effort to breathe, affecting, causing a drop in oxyhemoglobin saturation level, resulting in sort of bradycardic response. Finally, the patient wakes up here, and you can see the heart rate gets stimulated again, and saturation comes back up. Once that occurs, the patient will fall back to sleep. This is a 2-minute sample, so you can see this period of no breathing is almost 45 seconds. This is the information on a home-based study. While limited, it still is quite helpful in looking for obstructive apnea. Again, no airflow, continued effort to breathe, repetitive drops in oxyhemoglobin saturation level. The advantage of the home studies, they don't require coming to the laboratory, and right now in the corona virus era, this is a good thing. It's accurate for moderate to severe obstructive sleep apnea and may cost less because you don't have to come into laboratory. The disadvantages, we don't know what the impact of a lot of other medical comorbidities are on the accuracy of testing. You can't detect any other sleep disorders other than sleep apnea. A higher failure rate because nobody's there to replace leads that fall off. And for mission critical testing, such as in truck drivers, you don't know who takes the test since you're not observing them. That being said, most studies done today are being done as home-based tests. Now that you know the patient has apnea, what do you do about it? Well, treatment, there are 3 different types of treatment: behavioral, medical, and surgical. Behavioral interventions are those things you can do in changing their behavior that will affect the disorder, the big one being losing weight. Also avoiding things that affect muscle function, alcohol and sedatives, avoiding sleep deprivation because that also affects muscle function. Some patients have apnea only in the supine position, so avoiding that can be treatment, but you have to document that that's indeed what they have. And of course, if you need another reason, telling people to stop smoking. This shows the impact of weight. As weight goes up, you get more events. As weight goes down, and it's a pretty linear relationship. So this is a very effective treatment, but as all of you know, this is a very difficult thing to get people to do successfully. As a result, we often go to other treatments. The medical interventions include positive airway pressure, of which there are several types: continuous positive airway pressure, in which you deliver the same pressure throughout the respiratory cycle; bi-level positive airway pressure, or BPAP, which you vary the pressure during inspiration and expiration; and automatic titrating, or AutoPAP, in which it's essentially CPAP, but it varies by breath to breath depending upon need. There are also oral appliances, and there are other adjunctive treatments, medications, or oxygens, but have a very limited role because they have only a small impact on the disorder. This shows positive airway pressure, in which air is delivered through a nasal mask to the airway to splint it open and prevent the collapse that you see here. Advantages, it affects blood pressure. This is a 3-month trial randomizing people to CPAP versus sham CPAP, or ineffective pressure level. And after 3 months, you can see a 10 millimeter drop in mean systolic and diastolic blood pressure compared to no change or worsening in the control group. Mortality, this is an observational treatment looking at patients who are untreated versus treated. And you can see the group on CPAP is essentially at the same mortality rate for fatal cardiovascular events as those with no apnea compared to those with severe. Performance, this is a driving simulating test, something called a steer clear, in which you sit at a computer and drive and cows pop up. And if you fall asleep, you hit the cow. So you basically measure how many cows you hit. And what you see is people with apnea have worse performance that improves after CPAP to the point that it's essentially the same as those without the disorder. The big issue is compliance. When we first started putting PAP on people, they said, tell us they were using it. It was great. We reported 75% of people were using it effectively. Then we got a little bit smarter and put devices within the PAP machines that could measure usage. And the first study that came out showed that less than half the people were using it at least 4 hours a night, 5 nights a week. So it's important to include a program for monitoring and improving compliance. And if you do that, you can increase back up to the rates that we saw earlier in terms of usage. It's also essential now, since the payers know about this, they are requiring demonstration of compliance in order to continue reimbursement. And they use as their target that they use at least 4 hours a night, 70% of the time. If not, they will stop paying for the device and supplies. Fortunately, we're able to track and monitor this well now, since most of the devices come with monitoring systems. These are the sorts of information that you get, shows overall usage each night, and you can even track each day how much they're using the device. For people who can't tolerate PAP, oral appliances are often the second line. Indications are people with mild and moderate apnea, not as effective in severe, with success rates in the 50 to 70% range. Because the efficacy is variable, you need to document its effectiveness with a sleep study while they're wearing it. Side effects can include temporomandibular joint discomfort, shifting of the cheek, and salivation. This shows the most common type of mandibular advancing device, which anchors to the upper teeth and then shifts the lower jaw forward, pulling the base of the tongue forward and opening the airspace. The third option is surgical. Then they fall into, there are a number of different surgeries, and they fall into different categories: bypassing the upper airway or reconstructing it. Under the bypass is the first and still most successful treatment for sleep apnea, which is tracheostomy. However, most patients really don't want a hole in their neck, and so we've looked at other options. And there are surgeries that have been done anywhere from the tip of the nose all the way down to the hypopharynx, removing tonsils, correcting nasal septum, and removing excess tissue. This is the most common one done, the uvulopalatopharyngoplasty, in which you remove the uvula and part of the palate and sew the anterior and posterior tonsillar pillars together. Success rate on this is about 40 to 45%. This is a genioglossal advancement in which the genioglossal tubercle is moved forward, pulling the tongue forward, adds about 5 to 10% to a UPPP procedure. This is the most comprehensive surgery. It's called a maxillary advancement, in which you break the upper and lower jaw, move them forward, rewire it. In specialized centers that do this, success rates have been reported about 90%. However, it's pretty extensive surgery. Jaw is wired shut for a month. Patient changes the way the patients look as well. The most recent surgery has been electrical nerve stimulation, specifically the hypoglossal nerve. In this case, a pacemaker is implanted in the chest wall that detects efforts to breathe. And then the wires run up to the hypoglossal nerve, which is involved in maintaining airway patency. This is from a multi-center study in which patients were put on the device. And what you can see here is looking at the number of events at baseline, and then at 12 months, they're able to maintain the benefits, which you then see the reversal in the group in which it was turned off. They go back to their pre-treatment status. About 66% of patients are responders, with about 30% getting to total cure. Currently, it's being done under protocol. So patients with a BMI less than 32 and moderate to severe apnea with an apnea-hypopnea index of 20 to 15 an hour, and usually at specialized centers. So here's another case: 47-year-old male diagnosed with moderate OSA and treated with CPAP. After 3 months, he complained of continued sleepiness despite sleeping 8 hours per night. He reported no change in weight and still was sleepy while driving. The question to all of you is, what should you do next? CPAP or start on medication. As most of you voted for, the answer was check compliance rates. So when you take a look at reasons why people don't improve, probably the most common is they're not using the machine enough or in an effective manner. And so that needs to be the thing that you check first. Other things that can cause continued symptoms despite use, poor sleep habits, meaning they're using the device, but they're not getting enough sleep. That can also give you sleepiness. Anything that might overcome the pressure of the machine, such as alcohol or sedative use that affects muscle tone. Depression sometimes can present with at least symptoms of fatigue, tiredness, and so you need to differentiate that. Again, weight gain can overcome the effect of a preset PAP level, or if they have some other sleep disorder that's not apnea related. So if they continue to have persistent or recurrent symptoms despite good use, that's when you should refer them back to the sleep specialist. So just to summarize, and hopefully I was able to show you that these things we stated at the beginning were correct, that sleep apnea is dangerous in terms of having significant cardiovascular and other consequences. It's common with a high prevalence and has been getting even more so as with our obesity epidemic. It's easily recognized and you should be able to screen for these in your routine health maintenance exams, and it's treatable. And so just to end with our happy couple now taking care of the problem. So I'll stop here.
Well done, Larry. They look very content and sleeping well, right? We do have time for a couple of quick questions, maybe quick answers. There are a lot of penetrating questions that maybe we'll come back to during our Q&A session. But here's one. What's the most common cardiac arrhythmia that you encounter in obstructive sleep apnea?
Probably the most common is what's called a tachybrady dysrhythmia. We see that variation we saw on the polysomnogram, but the one of clinical consequence is atrial fibrillation. And data suggests that in patients who have atrial fibrillation, not treating their sleep apnea makes it very hard to control it. And in fact, success rates from ablation therapy go down significantly if you don't also treat the sleep apnea.
In 15 seconds, can you tell us, do you ever use a hypnotic to help people adjust to the effects of the CPAP?
Yeah, sometimes if it's the people just can't get to sleep while they're adjusting to it, I will give them that for a few days to help.
Great. Perfect. Well done. Thank you so much.